Hi everybody, I'm David Norre and welcome to this webinar where I'm going to try to give you some insights about the biological approach in dental implantology and especially the choices I make when I choose an implant. There are two important peoples in my dental education who give me my insights, and the first one was Professor Injas Naert from the Department of Prosthodontics at University of Leuven. During my prosthodontic training, he said us that the most important part about prosthodontics is a stable abutment implant interface, because then you have less losing of the screw. And the second one was Professor Eric Rompen from ULG of Liège. And for him, for having implant success on long term, you need a very thick, stable keratinized tissue. And he was also the developer of the curvy abutment with Nobel. With these insights, I started my own practice, a reference practice to implantology, and today I'm going to give you an overview of it. We have three types of integration. Of course, it's important to have an osseointegration, and that we know is given by the bone around an implant, and that's decided by the micro and micro topography of implants. The second integration is a gingival integration. This one is given by an abutment material and a design of this abutment. And of course, we have a sort of aesthetic integration. And all the cases you're going to see, there are nice crowns. It's all done by dental technicians. So the dental technicians are the real artists. The only question we have to raise in this integration is what's the role of the abutment? The abutment, is it something who gives a sort of osseointegration? Is it the surgical part? Or is it the prosthodontical part? Is it something that dental technician has to design? Do we have to choose something? Is there a difference in osseo and aesthetic integration? So we're also going to give a big part about abutment design. Because the question you have to raise is, does the gingiva know by what it's supported? Most of the time, people said, yes, you have to give pressure to the gingiva, or you may not give pressure to the gingiva. But the gingiva, does it know? Does it know if there is an abutment beneath it? When you see this case, there is no abutment, there is not even an implant, it's just a bridge, and you have papilla and you have gums. In this case, it's an orthodontic patient with mini screw implants. The implants are 2 mm diameter. There is no abutment design, there is anything. There is just a crown, and this crown gives stability of the gingiva. Another example is this one. It's a removable denture. It's a syncone, and you see almost papilla coming on top of the prosthesis, and there is no abutment. So does the abutment really know by why it's supported? What's the gingiva? What's the biggest difference between a gingiva of an implant and a tooth? When you ask it, they're going to say it's a periodontal ligament. That's the biggest difference. But what is the periodontal ligament? Why is it so important to have a periodontal ligament around the tooth and not around an implant? You can say, yes, you have your gingival integration of the connective tissue to the cementum, which gives stability to the gums. But when you look to the periodontal gingiva, you see it, that's a big difference between a tooth and an implant. What difference with the implant? You have a lack of connective tissue, that we know all. It's also hypovascular and hypocellular zone adjacent to the implant. But one of the biggest problems about the lack of periodontal ligament is the absence of blood supply coming through the periodontal ligament. But why is it so important? Why do we need the blood supply coming from the periodontal ligament and we don't have it to the implant? What does it mean? What's the problem about it? When you see the periodontal role of the connective tissue, is in fact there are three types of roles of the connective tissue. It's a protection. The connective tissue is in fact the only part of the body which protects the implant from the outer gingiva, outer space. So you need protection of the implant. You need protection of the bone. And from where it's coming, it's from the connective tissue. And the connective tissue, you have the biological protection. So it means you need blood supply that we don't have around implants, or not enough, to give some permeability around the tooth to protect the bone against the bacteria and things like that. We all know if we see periimplantitis, the gums are loosened of the implant. If if you blow it with your air spray, you see the gums opening and closing. All the bacteria can reach the bone and can reach the implant. So it's very important to have a stable connective tissue around implants. But also it gives a mechanical protection about food. So how can we see it in the mouth? What do we see? Is an implant, low-level implant, subcrestal implant. You should see 3 zones. Deep zone of the implant is a lower region and gives a hemidesmodon formation, which gives attachment to the titanium or the zirconia of the abutment. This type is necessary to the mechanical stability of the tissue around the abutment. That's why I think this one is the most important part of the gingiva when you use a one abutment, one time concept. You don't want to disturb this internal basal lamina, so you know it's stuck and it's never going to move. It gives the mechanical stability. The second part is the peri-implant epithelium. Like we described just before, it's really important because there you have the bilateral protection. You have a semi-permanent membrane, and it means that this one is much weaker than around a normal tooth. And then you have your peri-implant circular epithelium that is just for the aesthetics and the function. It's an implant, and what we're going to describe, what are we just describing, is this zone. It's a zone between the implant and the crown. So again, I'm going to ask the question, is an abutment more something prosthodontic or more surgical? It's, in fact, a little bit of both. And how does we have to design it? If it's surgically, a dental technician cannot design it. We have to design it ourselves. We have to say to a dental technician how he has to work. And this zone is characterized by 2 types. You have a platform shift and a conical connection. But what does it mean? What's a real platform shift? When you see platform shift is in fact an abutment who is smaller than the implant. And it means that you have less marginal bone loss, described by Stritzel in his meta-analysis in 2015. So it means if you have a platform shift, you have less bone loss than against platform matching implants. But why is it? Do we know why it is? Because platform shift is nothing new. It's already more than 30 years old. The first one was given by III. They had a wide implant, but they didn't have the mechanical and the prosthodontical parts to match the wide implants. You have in fact 3 hypotheses about abutment and platform shift. The first one is a mechanical factor. Inflammatory cell response is the second one. And the third one is a horizontal shift. What's about the mechanical factor? You know, when you load an implant, all the stress is given to the neck of the implant. So it means we have more stress and strain around the neck of the implant, and you're going to lose the bone till the first thread. If you change the abutment and make the abutment smaller, it means that these forces are not given anymore to the neck of the implant, but it's given into the implant. It's like a tube connection, but it means that you need a stronger and better interface between your abutment and your implant. The inflammatory cell response, as you see this movie from Hermann Zipperich, is in fact the fact that you know that the components can move if you have flat-to-flat surface or an internal connection. And by moving of this abutment, all the bacteria sitting into the implant are coming out, coming over the top of the implant and destroy the bone, and you lose bone till, again, the first thread or the biological width is installed. Of course, if the implant is wider and the abutment is smaller, the abutment moves and the bacteria stay on top of the implant. You don't have bone loss. So the second theory, because we don't know what's the real one. And maybe the third one, so you know it's Professor Inkevicius always told us, is that we need a thick gingiva. At least when you put an abutment who's smaller than the implant, you're going to raise more gingiva around the abutment because you make it smaller. In fact, you win almost 20 to 25% of gingiva. It means if you have a height of 2 millimeters, with a platform shift, you can raise to 2.5 millimeters. And everybody knows now that if you have less than 2 millimeters gingiva, you're going to have bone loss. So it means creating platform shift, you can reduce the height, but you win gingiva. So it's very important to use platform shift implants with narrow and thin gingiva types. But is every platform shift the same? Is it enough to have a platform shift? When you see this meta-analysis of Krakanovic, it means that when you have a less marginal bone loss against platform shift implants, it's the same result as previous studies, but he sees that the difference in marginal bone loss between the procedures was observed and was bigger in increase of time, so more than 1 year, and increase of the mismatch. So, or bigger the mismatch, or more bone you have. The question that you have to raise is, how many has the mismatch to be? Ruzeler did a study, and what did he saw? If you have at both sides 0.435 millimeters difference, it means an implant of 5 millimeters with an abutment of 4.1 millimeters, you have the best or less bone loss than smaller ones. So he said, okay, you need 0.45 millimeters for each. When you see the meta-analysis of Atier, it comes almost to the same difference. You need a platform shift of 0.4 millimeters to have favorable bone response. So platform shift of less than 1.4, it means 0.4, it means an abutment of 5 millimeters, an implant of 5 millimeters with an abutment of 4.2, so 0.8 millimeters difference, you have a good platform shift. So, but what does it mean if you have a platform shift? We already discussed it. There is a problem around abutments and platform shift, is the fact that these components are more sustained on stress. So you're going to have much more loading of the abutments. And it's why it's important to have a good titanium grade. We all know different companies, titanium grade 1, 2, 3, 4 in the past, time 25 and 23 are now more and more common. So it's really important, like you see in these graphics, that the titanium grade 23 is almost twice as strong as the titanium grade 4. So if you need a platform shift implant, think about to have an implant with a very strong and good titanium grade. In fact, the most implants used in medicine, in hip, knee, mini orthodontics implants, are titanium grade 3 or titanium grade 5. But then you can discuss, yeah, but it is the same because big companies, a lot of big companies telling us that you need to use titanium grades 4 because it's pure commercial titanium. When you look to all the studies in different biomaterials, scientific literature, you see that the bone doesn't see the titanium grade. It sees a titanium oxide layer. So it's very important if you choose a titanium grade, you just have to look to the mechanical strength of the titanium grade and not the biological properties. Why? Because the bone just sees the oxide layer of the titanium and not the implant. This one is also a study from the same group, which shows us that you don't see any difference of osseointegration between titanium grade 23 and titanium grade 4. So, what can we conclude about the implant abutment complex? That we need at least a platform shift of 0.4 millimeters. We need a strong implant abutment interface, and we need a very stable conical connection. That's the biggest difference. When you look to the implant, to the V3, what do you see? The implant 4.3 has a platform shift of 0.75, has a titanium grade 3, and have a conical connection of 6 degrees by 2 millimeters of length. So, following the evidence, is an evidence-based implant. There are also other things which making something characteristics about this implant is the fact of the V-shape and the micro threads. Why do we need micro threads? Because you know, if you have a flat surface, you're going to lose bone. It's like an implant with a smooth neck. You place a smooth neck under the bone, you're going to have osseorization and going to lose bone. This type of implant, especially with micro threads, you have to place it slightly subcrestal, like 0.5 to 1 millimeters. You need it to have stimulation of the bone and to have osseointegration. The other one is the micro threads, and the V shape is the fact that this case is, for example, a pocket seal technique, is to put the flat side to the buckle. So you win more room and it's much more easy to put the biomaterials in the depth. Like this one you can see, you win 0.3, 0.4 millimeters to better to reach the biomaterials. And something really nice, what I like a lot, is the flat apex. The apex is not sharp, it's flat. And what does it mean? It's easy to do summer techniques. Why? If you have a square point or sharp point, you're going to push it, and you're going to break the sinus membrane. This one is flat with an aggressive thread around the apex. It's going to push it, going to push the bone on top. This side you can see, it's a molar. I did it guided. I placed the implants almost 2 millimeters below the sinus membrane. I planned it. I turned my implant, and just by hand I put it deeper. What did you see? What did we saw? The fact that the membrane is pushed into the sinus and creates a summer technique without any osteotomes, without compression, just by the shape of the flat, not sharp apex of the implant. With all these concepts, what does it mean, in fact, clinically? What can we avoid? Why did we do that? For the abutment design and the gingival complex, it's very important to understand that you have two different types of teeth. You have the anterior teeth and the molar teeth. If you're going to see this one, completely other shapes. A molar and anterior teeth are almost a half the big, because you know a molar has 3 roots, anterior teeth 1 root. So you can ask yourself, do we need to have an abutment of the same shape? Is it the same? Can we just think about, yes, anterior teeth or molar tooth, we can do the same whatever we want. First, anterior. What do we know about anterior teeth? You know, extraction sockets are triangular. You see the implants can match very well this shape of teeth. But how do we have to design the implants? You know, you have a subcritical and critical contour and a button connection. Subcritical doesn't mean that it's not critic. It mean that you have to place the abutment lower, and a subcritical contour means that it's below the critical contour. The critical contour is, like I showed you in one of the first slides, it's the circumference of the tooth about the gingiva, which gives the protection and the mechanical stability. So we have different emergence profile. We have the S shape, concave shape, umbrella concept, like Professor Messalini is describing. So what do we need in the anterior zone? Everything depends about the position of your implant. I cannot say today you always need to do that type of abutment or that type of abutment. What do we need? We need blood. That we know. We need some support and need some protection of the abutment and the crown. How do we create more gingiva? Is to making the abutment as narrow as possible. Or more narrow the abutment is, or bigger the gingival interlock is, and you're going to have a stability, a mechanical stability, but also a biological stability of the gingiva. So what does it mean? If you place your implants slightly labial, to make your crown as concave as possible. So you have increase in soft tissue. Increasement of soft tissues give you much more gingiva around the implant and much more blood supply. And more protection, of course. If the implant is centered, and you place the implant in the middle of the extraction socket, you can make it slightly concave. Not too much, a little bit more, just to maintain a soft tissue at the right position. And of course, if the implant is placed completely to the palatal, you have to make some convex profile, just to push the gingiva to the buccal. That we know already with the past. What does it mean? The implant is placed slightly subcrestal. Why? Because you have a good platform sheet. You want to have the implant a little bit lower, that we can have bone growth on top of the implant. The first part, first 0.5 to 1 millimeter, give us the mechanical stability. So we need it just to have the hemidesmosome formation. There's a deep peri-implant tissue. This side gives us the biological protections. This is the site where all the blood cells are coming, and you have your semi-permeable membrane is going to protect against all the bacteria. So it means we need blood supply. We need a lot of blood around it. So make it as narrow as possible. So you have a thicker gingiva. In fact, it's like an umbrella. You're going to protect the gingiva. And the upper part is the aesthetic part. Excuse me, wrong side. And this part, it just has to be as wide as necessary to give the form of the gingiva and give the aesthetics of the gingiva. It's really important. It's logic. Why? Why is the tooth convex? If a tooth is flat, all the feet and the Eden going through the tooth, touching the gingiva and gives laceration of the gingiva. It's why we need to make something to protect. It's something like concave, like a tulip design. In anterior zone, this one gives the bone stability and has to be as narrow as possible, but very important, it has to be logic. It has to be titanium to have osseointegration and especially gingival integration, that you could have a sort of hemidesmal zone formation around titanium. That's a really important part, to be as biological as possible. And if possible, to place it once and never remove it anymore. That's why now, it's been a couple of weeks, months, a connect abutment is coming to the market. It's a little piece putting into the implant, torqued and never removed anymore, as narrow as possible. The part coming through the gingiva for the rest of the length has to be also as narrow as possible, but has to be the congruence through the aesthetics. So it has to make the form to the permanent teeth. And the permanent teeth has to be the perfect form 1.5 millimeters below the aesthetic part. So first part, as tissue, first brown line has to be aesthetic as possible, as biological as possible. Second part has to be as narrow as possible, that you have soft tissue thickness and integration of the soft tissue. And the last part, the last 1.5 millimeters to 1 millimeter, has to be as wide as necessary to have a maintenance of the gum stability. It's very important. So again, I'm going to raise this question. This abutment, a dental technician has to know the biology behind it, because all these parts gives us protection against all aggressive parts. So you need a very clean, stable, and well-thinked abutment. I'm going to show now some cases with just abutment design. Where there was no gingiva grafting. I'm not Professor Bicaccio, I'm not Professor Eric Van Dora, I'm not Galit Burrell, I'm not so manageable to make very nice and cool gingival grafting. I'm just going to show what you can do with abutment design. These patients came to my clinic with a lost canine. She had pain on the canine. We looked at it, we saw, oh, strange, we're going to do a retreatment of the tooth. So what do we see? The tooth was fractured in the buccal side. We decided to remove it, to do an immediate implantation. And the treatment plan of this case was extraction of a 13, immediate implantation, filling the gap with BioOs and LPRF, so BioOs block, using a healing abutment to close the socket, and that's all. It was the part I just did. Just remove the tooth, put the implant, no gingival grafting. Why didn't do gingival grafting with this patient? This patient was very, very anxious. So we just keep it simple. So we took just an impression, nothing special, thin tissue. We know the implant leads slightly to the buccal, thin tissue. So we have to make it as concave as possible. This shape as concave as possible, but as wide as necessary for the crown. I didn't do anything. I just put an abutment, I put the crown, retained it, was all. Starting dia, I just did crowns, nothing else, nothing special. I get gain. And it's logic. What would you have done if you had a free gingival graft on this canine? You had grind away a part of the canine to make a concave form and put gingiva. Here I just put an abutment, biological abutment, very nice concave form and a crown on top of it. Everything following the biology. What do you see? Gingiva is growing thicker, doesn't know by what it's supported, and creeping down. It takes a while, but you see it's after 2 to 3 years. After 2 years, gingiva is following maturation and becoming thicker. No gingiva grafting, you see no scars, anything. Just abutment design. The biology under it. You see, as narrow as possible, as wide as necessary. Very important. Place the implant subcrestal, believe in the conical connection of these implants. There is an abutment, titanium abutment of a titanium part to provide the integration of the hemidesmosomes above this titanium as narrow as possible and as wide as necessary for the crown. Second patient, the same, also very afraid, lost our anterior teeth. We have to remove it. Parietin gingiva. You know, for me, when I have to do a free gingival graft on the palates, I always say to the patients, it could be very painful. It's for 10 days when you eat, it's pain, you cannot eat very well. And these patients say, no, for me it's impossible. Just remove the tooth, aesthetics, we can see later. What do? I just removed the tooth, didn't do spectacular one. I just put a membrane around it to close it, just to have a sort of balloon that the gingiva is maybe coming or not. No gingiva graft, nothing else than just a membrane. With removable denture up top of it, and we let it heal. After healing, we put an implant, and we wait for 3 months. Maybe not the best way, maybe they have to do it immediate. It's okay, maybe today I will do it, but it's one of my first cases with MIS. This is a final restoration. We didn't do anything, just abutment design. We did the design of the abutment as narrow as necessary, titanium part as narrow as necessary, and as wide as possible. Again, this one is only abutment design. No gingiva grafting, nothing else than just abutment design. Just starting from here to there. We lost maybe a little bit, single crown. Maybe the form of the crown could be a little bit better, but look to the gingiva. Nothing changed. There was no gingiva graft, only and only abutment design. After 2 years, everything stable, gingiva doesn't move, no gingiva is going to resorb, just abutment design. No gray shining. If you work with very narrow titanium pieces, you don't see the gray shining around the implants or the gums. Another case, immediate loading this time. 2 teeth are lost. What do? We remove this tooth. We plant by guide to place the implants. When you plan by guide, I like a lot digital plannings, and I like a lot guided surgery. Most of the time I give lectures about guided surgery, and not about guided surgery itself, because I think I can place implants. It's for most of the part guided prosthodontics. In this case, it shows you very well what you can reach with guided prosthodontics. This case came to us, and what did we do? Yes, we don't have a good wax up. So we did just a pure digital wax up. This side, we just asked to MIS to put the tooth like it has to be. We designed it on the wax up, on the MSoft software. They designed the crowns, and I asked to make a guide in the right position, deliver me the abutments, and deliver me the crowns. I received everything, and we placed the 2 implants, guided, in extraction sockets. You see it like we did before. The big advantage of the flat surface of the V3 is for 2 reasons. It's important because you know now how the index is, because in the software you can plan the flat side of the implant to the buccal or to the distal or to the mesial, but here we plan it to the buccal. Why to the buccal? Is for me it's much more easy to insert biomaterial in front of a flat side than around the round side. You see it better in the right side, you win a lot of space to fill it. And you have your 2 ears to support a little bit more the papilla. And the same session, we make a little bridge, we put it, always use, it's very important again, to use biological parts coming through the implant. Don't try to use a button shorter than 1 millimeter. Use a 1.5 millimeter coming through the gums. And again, as narrow as possible. This picture is after, I think, 4 months of work. And it is the gingival integration. You see a little bit volume loss on the 11, but biologically everything went fine. Then one of our colleagues clinic are doing the prosthodontics. Then we go from digital to analog again, design it, make individualized impression coping. Again, just like we always do. Took the impressions with the individualized impression copings and sent everything to then the lab who manufactured 2 single crowns of these implants. This is the result, again, without gingival grafting, only abutment design. You see, very thick, stable tissue around this anterior implant. Think about the fact that if you use a narrow abutment, then you have volume gain. Volume gain means more blood supply. More blood supply means a lot, like we discussed before, protection, stability, everything. So a big gingival type with a small, narrow abutment. Now the X-rays of these 2 implants, immediate loading of 2 teeth in anterior zone with everything done up front. Very important abutment design. As narrow as possible, as wide as necessary. Starting on the upper side to the lower side, just 4 to 6 months. This side you can see a little losing of the volume of the 11, but there was a big infection. Now, we talked about our anterior teeth. We have to make as narrow as possible. But what do we have to do with molars? Is it the same? Is it more the same concept as for anterior teeth? Our widest implants, even the widest implant on the market, not even comes close to a molar. You see the 6.5 millimeter implant of Straumann is not even as big as one root of a molar. So I don't know how you're working, but in the past I did that way. We just place an implant and we put an healing abutment on top of it. Implant is placed guided in the center of the tooth, healing abutment. Like this exists for 40 years. We took a digital impression, full digitally. Bone levels are perfect because I had a good platform shift, I got a good connection, so everything went fine. Took an impression, digital is very nice to work digital with the tree shape. The occlusion, look how beautiful the gums are, everything fine. I have a big gingiva around it, so I'm happy, it's stable. The crown made by the dental technician, everything's going by fine. The crown is placed, patient is happy. Say, ah, nice, it's beautiful on my own teeth. I bite. And sometimes you can say 2 things. The first thing in my office they complain is they look to the gum and say, does the gum coming back? Then you can say 2 things. You can say, yes, of course they're coming back, just wait 6 months. We all know that they're never coming back. So we can be honest and say, no, it's an implant, it's 4 millimeters, it's much less wide as a tooth, so it'll always be there. And after 6 months, the patient comes to your office, or after 1 year, and you ask them, how is it going with the implant? They said, yeah, very well, I can eat everything, but it's very annoying. When I eat salads or tomatoes, I have always to go with my tongue to remove the food stuck in the buccal side of this implant. And then I was starting to think with one of my friends, with Thomas, and say, yeah, isn't there some concepts about healing abutment? Because, yeah, and healing abutment is round, 4, 5, 6 millimeters, 7 millimeters. Is there another possibility to have wider abutments? Can we not find something to work in the digital process? And here you can very well see the big problem of the gums. That's the zone of interest. Were you happy? But no, I have a lot of cases. A lot of these cases are from my office, so I've seen. And all these patients complain about food stuck around molars. If you look to the literature and you ask yourself how many implants are placed in molar region, it's almost 40% of your implants is placed in molar regions. And most of these cases, patients are complaining about food stuck. If you look to the literature, you see that there are more and more literature coming about something to a supra-implant immersion profiles with CAD/CAM techniques or with VPI or with composite. You have different techniques to manage it. But what, if you see this patient, what would be the best tooth for filling the gap in the second quadrant? What is for you the best? For me, the best would be to have a copy, a clone of this tooth, that I could take this tooth and put it there. For me, that would be the best solution. Is that possible? No, of course not. But what can we do? What can we copy? What can we form? From this CBCT, what can we do from this CBCT? We can remove this abutment, this tooth. We can take it out, this CBCT. We can mirror it and place it. It's a digital cloning. But what does it mean? Have we something about it? It's cool, it's fancy. You can just take a tooth, you can show it on CBCT, but what can we do? In digital world, we can do anything we want. Your imagination is really the best thing you can do. This tooth removed, we mirror it, and we ask at M Center to make a copy of the roots for a healing cap. It means that you have to place the implant guided. And if you place the implant guided, you know where the implant is placed, and you know where the implant is placed. The dental technicians can make a healing abutment with the form of the contralateral teeth. What does it mean? In this case, you plan digitally the implant, you plan digitally the healing abutment. This healing abutment is a perfect copy of the contralateral tooth. We did a sinus floor augmentation, we placed the implant, and in the same session, we placed the abutment. And here you see the abutment. What's very special in this abutment? It's because you work on a conical connection. It's very difficult to fit. With the MSoft, you can plan again the flat side of the implant to the side you want. And if you know that you plan the flat side of this implant to the buccal, you can place your implant guided to the buccal with the flat side. And if one flat side is placed to the buccal, you know the healing abutment is going to fall into the implant. So now you can choose the left side is with individualized healing abutment, the right side is with your conventional healing abutment. Remove. Why? With the it's a extractor. The second picture is an extractor. Why do you need it? Because it's a conductor connection of 6 degrees by 2 millimeters. It's very, very stable. So we know that all implants have bacterial leakage into the abutment. But if the abutment is so tight and so screwed in that you don't have micro motions, you don't have bacteria inside of it. So when you remove it, you cannot remove it, you cannot pull it. So you have to remove the screw inside of the abutment and remove it with an extractor. When you remove the abutment, you see the gingiva. Then you scan the implant. Or you can take a conventional impression. It's not a difference. But you don't see any analog step. You don't see any composite around the gingiva. I was a little bit discussing about because it's bleeding when you remove this abutment, because you remove the hemidesmosome, the attachments, it's bleeding. If you put some tie bases or things like you want, then you put some monomers, some composite, you fill it, and you put some light on top of it. Try to put some bonding on your nail, and then make with your lamp, make it hard. You're going to see it's going to be very hot. What I've seen, I've done things like that. Afterwards, all the cells are not dead, but a strange color. It's not the same picture I've seen around titanium or zirconia. So this one, you scan with a scan body, no impression, no individualized healing abutments, nothing. You can even do it with Impregium or with Elginet, whatever. The difference is now, especially with a scanner, you never can scan the depth of this form. But what do you have? You are in a digital patient. You have the STL files of these abutments. So it means you took your impression, you scan it, you see again, it's a case with a sinus floor augmentation, implant is placed as stable as possible. We scan it. And then what do we have? We have the STL file. We have the digital design of this healing abutment. You can ask MIs to send it to you, the STL file, and you export it. You export this STL and you receive a picture like this with your abutment. What can happen? Your dental technician can import this STL in his AutoCAD, in his 3Shape software, and put it on top of your implant. And on top of these abutments, you can just design a tooth with a perfect emergence profile of the abutment you have made up front. So from the abutment, pre-op to placement, the crown has the same form. And think about, what do we need for more? Per definition, a molar is an implant placed to the palatal. It's never placed to the buccal. It's not like an anterior tooth, because what do we have as problems for anteriors is the implant is often placed too much to the buccal. So we have to make a concave abutment. For molars, it's per definition an implant placed more to the palatal side. So what as we showed and what Victor Clavijo showed is that if the implant is placed to the palatal side, you have to give gingival pressure. And to give gingival pressure, you have to design it. And this is designed by the healing abutment. So make the abutment as narrow as possible coming through the gums to have the protection of the gingiva, and then make it as wide as necessary, 1.5 millimeters lower. The picture, and often, I don't know what it was for you before, but when I wanted to place crowns like this without individualized healing abutments, you have to cut the gums, or the patients are crying almost when you torque the crown. This is one-on-one. This is a crown. The gingiva is still a little bleeding. Just look, it falls into the gums. No pressure, perfect emergence profile, nothing else. Just screw it, torque it. Patient didn't feel anything. No anesthesia, nothing spectacular. Perfect copy milling of the contralateral tooth. Crown and the buccal contour. When you think about this is extraction, immediate implantation. This extraction, let it heal, place the implants. But when you think a little bit farther, it's next concept. It's about the fact that maybe you can do it also in immediate loadings or immediate extraction and implantation. This patient has lost our two molars. One of the first pictures was our husband. She came to me and he said, yes, these two teeth are lost, we have to remove it. But my husband always complaining of his gums. I don't want to have implants because I've always food stuck around his implant and it's really annoying and I'm much more nervous as him. So can you do anything else on it? I say, wait 1 second, maybe we have something to help you. So we know these two teeth are lost. You can see the clinical picture here. What do? We just make it digital, patient. We scan them out. We took a cone beam of the mouth, a full, and we plan digitally the two implants. To plan the implant, the most difficult part is to know, to expect where the implants could have more or less stability. So you plan the implants, and you ask the dental technician from M Center to make a healing abutment with the perfect form and the perfect shape of the tooth that has to be extracted. You can see it here. Everything is in software, everything digital, it's easy. I just took an X-ray and I just took cone beam. And the most difficult and the most important part is to plan it and to know how to design the abutment. Again, all these abutments have a conical connection indexed. So you're going to take the index. If you try to do it with a 6-8 lobe, it's very difficult. Try to plan, again here, the flat side of the implant to the side you want, but remember it. Most of the time I put it in a buccal because it's easier to manage. You plan the implant with the flat side of the implant to the buccal, why you want to fit it that way, and you know how the implant is placed. And these are the designs of the healing abutments. I didn't do anything. I did just the planning. They designed the abutment the perfect shape of the tooth. To place the implants, buccal, flat side to the buccal, especially in extraction sites. It's always nice in a lower jaw to place an implant with a flat apex. Why? For not chopping the nerve, that it's flat, then you know when you stop it. And aggressive thread in the apical part to take your compression in the extraction sockets, but a smaller design in the upper part to just you can fill it. 2 implants, 2 healing caps, nothing more than that I did tell you. And it is the healing. I did the extraction, first part, I placed 2 implants, and I placed 2 healing abutments on top of it. It is the healing of the case immediate. Extract the tooth, implantation, healing abutment. Everything in once. You see still little parts of LPF and the bios blocks coming through the gums. And it is a CBCT I took afterwards. You see, even in 3D, you have bone formation around these implants. It's very great, good surface, good primary stability. The V-cut allows us to put some biomaterials around it. The healing abutments can close the gums in once. Procedure took me 45 minutes. You can do it with VPR, you can do it with composite, I'm sure, but for me, I prefer that everything's go planned. And the biggest advantage is we have the emergent profile of this healing abutments. You scan the two implants, your full digital workflow, perfectly possible. Again, it's impossible to scan completely the contour of these implants. So you just do the scan bodies, you ask your STLs, they send you the STLs, and they completely can copy the healing without compression. So we have design of the crowns, completely following the CAD-CAM, the CAD design of the healing abutments. The CAM, the manufacturing of the crowns, are again following the biological principles. The first 1 millimeter has to be as narrow as possible, biocompatible, strong, that you have your hemidesmosal formation. The part on top of it has to be as narrow as possible and as wide as necessary for the crown. Again, very important to use a good contact point. The zirconia in contact of the gingiva is biocompatible, and to have clean parts. It's a completely other story, but how we can create clean parts. So for me, it's very important to have the pieces coming through the gums. The first 1 millimeter has to be perfectly clean. So read the literature about cannula or maybe some detergent, how to clean the abutments. It's very important if you work with implants with a connector connection. This is the day of the insertion. You see, everything went fine. The gingiva is perfectly red, has a good form. 6 months after placement, no recession, no changing, anything spectacular happens. Crowns. What did I do? We did some patients like this. After 1 year, we retook a tree shape around these implants to see, can we keep the volume of the gingiva 1 year after we did the surgery. We matched pre-op and post-op 1 year after. So the left side we did before we did anything. The right picture is 1 year later. Then we put in a software to match these both. Then we can see the volume. What did we saw? This is a superposition of both scans. You see, at the first molar, we will have just a losing of about 0.23 millimeters in width, even some gain. And on the 47, or 37, we have much more gain because the pink is coming through the model. So we have even more volume than before. It's also logic because when we designed healing abutment, we put the tooth a little bit more in the correct shape of the bone. This is X-ray, 24 months post-op. You see very well biological integration of these implants. The V-neck is completely filled with blood. You have a flat apex. If you look to the right X-ray, you are 1 millimeter from the nerve. Very stable implant in the extraction sockets. You don't have a sharp point that could touch the nerve. The only thing I would say is you cannot do your job with just the methods and would do in business tomorrow. Thank you for attention. I don't know if there are questions.